Now, of course, I have to get everything back in order. The legislative hearing of the Subcommittee on Health will now come to order. I'd like to welcome all members and witnesses for today's hearing. We look forward to a very productive discussion on some impactful veterans legislation. Today we'll discuss 12 bills, including bills which would enable the VA to enter into innovative public-private partnerships, research cutting-edge hyperbaric oxygen therapy, and provide some long overdue oversight of the VA's budget management. Also on today's agenda are 4 bills I've had the pleasure of introducing. Before I discuss my bills, I'd like to thank our witnesses again for being here today. I'd like to especially thank Dr. Andrew Kosminski, who is the medical director of the hyperbaric medicine at my beloved University of Iowa. I had the pleasure of touring Dr. Kosminski's office a few months ago and learned about the incredible healing properties that hyperbaric oxygen therapies can provide. Dr. Kosminski, welcome to my office. And I'd like to look forward to hearing your thoughts about Dr. Murphy's bill, the Veterans National Traumatic Brain Injury Treatment Act. Now to my bills. First, the Sports Act. The Sport Act would make sure athletic prosthetics are defined as medically necessary for amputee veterans. Every year in my district, severely disabled veterans gather to play golf. I'm not a golfer, except for miniature golf, but it's amazing to see how many sports, even golf, can improve veterans' mental and physical well-being. I think all veterans should be able to enjoy the benefits and camaraderie sports provide, and my legislation would achieve just that. I'm also proud to introduce the No Wrong Door for Veterans Act. This bill would reauthorize VA's successful Fox Grant program. Fox grants enable community organizations to provide services to veterans, screen them for suicidal ideation, and connect them with the VA so they can receive the mental health support that meets their individual needs. My bill would ensure organizations who have been successful in our mission to expand mental health can receive additional funds by partnering with the VA to reach even more veterans. The Fox Grant program is a great example of a public-private partnerships working for the better. House Republicans will continue to push the needle and protect programs like this one. Next, I'm proud to lead the Providing Veterans Essential Medications Act. This bill would allow the VA to provide very high-cost medications to severely disabled veterans receiving care at state veterans' homes. VA pays for these medications for all other veterans' patients, but antiquated laws require VA to pay state veterans' home a fixed per diem, limiting their ability to provide for veterans who desperately need these medications while residing at a veteran's home. Unfortunately, these high-cost medications can cost as much as $1,000 per day, meaning state veterans' homes are not able to house many of our most deserving veterans. My bill would fix this clear mistake and ensure veterans with complex needs are cared for. And ironically, the last bill I'd like to mention is the START Act. Far too often, our veterans receive community care referrals that are only valid for a fixed period of time. But due to provider shortages and bureaucratic delays, veterans might not even get in until halfway through the authorized time period. My START Act addresses this issue by ensuring that the validity of the referral begins only once a veteran has attended their initial appointment. It's pretty common sense. It's a privilege to collaborate on crafting impactful legislation for our veterans and to address critical issues in the delivery of their health care. I'd now like to turn to Representative Brownlee for any opening remarks she may have. Representative Brownlee, you are now recognized.
Thank you, Madam Chair. At the outset, I have to say I find it a bit crazy that we're having a legislative hearing today rather than an oversight hearing. The Trump administration's executive orders, mass firings of VA employees, reckless contract terminations, and $1 spending limit on purchase cards are causing significant upheaval within the Veterans Health Administration. That we are here today proceeding to consider new legislation as if these changes aren't already significantly impacting veterans' access to care is absurd. Our time today would be much better spent examining the administration's plan to gut VA's workforce by 80,000 employees before September. This would be in addition to the 2,400 or more VA employees who have already been terminated. Committee Democrats have already heard a multitude of instances of these terminations negatively impacting patient care, despite Secretary Collins insisting that they're not. The terminations that have already occurred include positions like procurement professionals who play a critical role in purchasing prosthetics and medical devices veterans need. We are aware of numerous VA medical facilities where such terminations have occurred. Supply chain staff who are responsible for equipping surgical suites with necessary supplies. The committee has heard from several supply chain professionals who were terminated from the VA facilities in Florida, Texas, Oklahoma, and in California. Human resources professionals who are necessary for filling clinical staff vacancies, while clinical staff have largely been exempted from the Trump administration's hiring freeze. VA can't efficiently fill clinical positions without human resources professionals. Psychology technicians at the Cleveland VAMC who perform neuropsychological tests for individuals with neurological conditions like strokes, TBI, PTSD, and concussions. Staff that perform, manage, and analyze mammogram results at the Hampton VAMC. One veteran whose mammogram was canceled due to a staffing shortage at the Hampton VAMC just found out the earliest she could reschedule her appointment elsewhere is June, 4 months from now. These are just a few examples that the committee has heard about from across the nation. Unfortunately, none of the bills we are considering today will address the very real threat to VA healthcare, access, quality, and safety that veterans are facing. In just the last few days, my Democratic colleagues and I have received tens of thousands of emails from veterans across the country asking that we do all we can to stop the VA workforce cuts and eliminations of crucial contracts. I certainly hope that our Republican colleagues are receiving the same messages. Veterans do not support these cuts. I would encourage the witnesses and members here today to keep in mind that if we continue to see efforts to dismantle VA by firing hardworking employees, canceling vital research, terminating healthcare contracts, and eroding veterans' trust in VA, it won't matter what excellent legislation we put forth. There won't be employees or even an infrastructure left at VA to implement these bills, and veterans' care will suffer because of it. I would hope the chair shares these same concerns, and I understand that we must protect the many VA employees that provide critical care to our nation's veterans. However, I understand that despite what I have laid out today, we are here to consider legislation today on this committee. I'm pleased today's agenda includes my VA Marriage and Family Therapist Equity Act. I'm also glad that a bill I am co-leading with my friend from Texas, Congresswoman Garcia, the Women Veterans Cancer Care Coordination Act, is on the agenda. I look forward to hearing from our witnesses on all of the bills on today's agenda. With that, Madam Chair, I will yield back.
Thank you very much, Ranking Member Brownlee. We have a full agenda today, so I'll be holding everyone to 3 minutes per bill to ensure we can move in a timely manner. This morning, we're joined by several of our colleagues who will speak in support of their bills. We appreciate the dedication to serving our nation's veterans. With that, I ask unanimous consent that all non-subcommittee members be waived on to speak on their bills from the dais. Hearing no objection, we'll move forward. I now recognize Representative Womack for 3 minutes.
I thank the chairwoman, Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of this subcommittee. Thank you for considering my bill, H.R. 1107, the Protecting Veteran Access to Telemedicine Services Act of 2025. I also want to express my sincere gratitude for allowing me to speak in support of this legislation. This bill aims to guarantee that our nation's veterans, whether in bustling cities or remote rural areas, have continuous access to the health care services they need and deserve. The Ryan Hyde Online Pharmacy Consumer Protection Act, enacted in 2008, was designed to regulate the prescription of controlled substances via telemedicine in response to the rise of online pharmacies and the risk of misuse. While this law plays a crucial role in protecting public health, it has not been updated to reflect the realities of 2025. Nor does it account for the fundamental differences between the VA and civilian online pharmacies. During the COVID-19 pandemic, The Ryan Height Act's in-person consultation requirement for prescribing controlled substances was temporarily waived. The DEA and HHS later extended these flexibilities through the end of this year. My bill, the Protecting Veteran Access to Telemedicine Services Act of 2025, would make this exemption permanent for the VA, allowing VA healthcare professionals to prescribe medically necessary controlled substances via telemedicine under specific conditions. This exemption has been a lifeline for our veterans. Without it, many will face severe restrictions in accessing vital health care. For veterans in urban areas, letting this exemption expire would mean longer wait times for in-person appointments, further straining an already overburdened VA healthcare system. The impact is even greater for veterans in rural communities, where geographic isolation and limited healthcare providers create significant barriers. The exemption has allowed them to receive care from VA specialists hundreds of miles away without the burden of costly and time-consuming travel. Continuing this exemption isn't just a matter of convenience, it's a necessity. It ensures that every veteran, no matter where they live, has equal access to the care they've earned and deserve. So I'm honored to speak in support of this legislation today. I urge my colleagues to act swiftly in passing the bill. Our veterans have sacrificed so much for all of us. It's our duty to ensure they receive the care they need in a way that meets the demands of today's world. Madam Chairwoman, thank you for the time, and I yield back my balance.
Thank you very much, Representative Womack. The chair now recognizes Representative Garcia for 3 minutes.
Thank you, Madam Chair, and thank you to the ranking member for giving me a few minutes to talk about my bill, the Women Veterans Cancer Care Coordinator Act. I'm pleased to lead this bill with Ranking Member Brownlee to improve the breast and gynecological cancer care that the VA provides to our heroines. Every day, more and more American women sign up to serve in the U.S. military. And as women sign up, the women veteran community also grows. In fiscal year 2000, women veterans made up just about 4% of all the veteran population. Today, they rank at about 11.3%, over 2.1 million women veterans nationwide. However, as the women veteran community ages, breast and gynecological care rates in this population will also increase. The VA responded to this need by establishing the Breast and Gynecological Oncology System of Excellence in late 2020, a program that ensures women veterans are getting the appropriate cancer care they deserve. The VA also partners with community care providers to treat these veterans when the VA does not have the means to provide care. Now that sounds great, but the system that we set up for women is not entirely working as it should. Veterans must navigate multiple facilities alone and ensure that providers communicate with the VA. The lack of coordination between both the VA and these providers lead to treatment delays, miscommunication, and unnecessary stress. Without a well-coordinated care team, a lot can go wrong. No veteran fighting cancer should struggle with red tape. They should be focused on getting better. My bill will effectively address these challenges by creating dedicated regional cancer care coordinators at the VA. These professionals would guide veterans through their treatment journey, improve communication between the VA and community care providers, track patient progress, and address the existing delays in their care. These coordinators would also provide veterans with emergency health information and mental health resources to support their well-being. I firmly believe that a grateful nation shows its gratitude in the care and benefits we provide to our heroines. Supporting our veterans is one of the solemn promises we have made, and it is a promise we must keep. Thank you again, Madam Chairwoman, and of course to Ranking Member Brownlee for her support on this issue, and I yield back.
Thank you very much, Representative Garcia. The chair now recognizes Representative Dr. Murphy for 3 minutes.
Thank you, Madam Chair, and thank you, Ranking Member Brownlee. Delighted for the second time to introduce my bipartisan bill, H.R. 1336, the Veterans National Traumatic Brain Injury Treatment Act, being discussed here today. It's long overdue that we do something further for our veterans who suffer from PTSD and TBI. Sadly enough, we lose 17 up to 22 veterans a day due to suicide, many who are suffering from TBI and PTSD. I'm a big fan and have been for over 30 years of the treatments of hyperbaric oxygen therapy. We've used this in surgical wounds for wounds that won't heal. It has enjoyed great success amongst many different maladies. It has been my own experience now in exploring this issue for TBI and PTSD that this is not only a viable, but a very, very successful intervention. I'm going to introduce into the record a meta-analysis study from NIH. This was done in January to March of 2020, which is an exhaustive list of mostly randomized, double-blind control studies, which shows great objective improvement for those veterans who have suffered from TBI and PTSD, not only in cognitive function, but mood disorder. Ask this be submitted for the record. This organization now, HBOT for Heroes in North Carolina, has successfully treated over 200 veterans who suffer from TBI and PTSD. We had a witness here before, the executive director, Mr. Ed DiGirolamo, who gave very compelling testimony at a roundtable concerning alternative therapies specifically for HBOT. My bipartisan bill sets up a pilot program for 5 years at 3 veterans service networks. Costs are borne by donations, not to the taxpayer, but by donations. The veteran service organizations are supportive, multiple enlisted here. We also have expert witness from Dr. Andrew Kosminski, an MD from the great University of Iowa, I think somebody went there or knows there, who is a hyperbaric oxygen medicine specialist. I have thought this through and through. I believe it is sad that we get our veterans when they hit the wall, when there is literally nothing else that the VA can offer, that we are not offering this therapy to them. It is a proven alternative and a successful alternative. And I will say it again, and I've said this before, I believe it is medical malpractice that is not being offered to our veterans at this point in time. So I thank you for your support. I would ask that this committee at some point review this favorably, bring this to the floor so that we can get our veterans the care that they need. Thank you, Madam Chairman. I'll yield back.
Chair now recognizes Representative DeLuzio for 3 minutes.
Thank you, Chairman Miller-Meeks, Ranking Member Brownlee, and members of the Health Subcommittee. It's great to be back with all of you, and appreciate your flexibility working with me and my team on my bill and considering this important measure to reduce veteran suicide. The Saving Our Veterans Lives Act of 2025, it's H.R. 1987. I'm proud to say this has been a bipartisan effort from the start. And although they're not here, I commend Representatives Fitzpatrick, James, and Landsman, alongside Senators King and Sheehy, and a wide variety of organizations who have come together and worked with me and others on such an important issue of veteran suicide. This bill will create a program at VA to provide and distribute gun lock boxes to veterans, including those who aren't enrolled with the Veterans Health Administration. This aspect of the bill is very important. Cited in VA's 2024 National Veterans Suicide Prevention Annual Report, the rate of veteran suicide is about 17.5 per day, and the majority of those terrible deaths are from veterans outside of VHA. So we've got to do a better job at reaching these veterans and connecting them with resources that could make a difference in their lives, and this bill will help bridge that gap. So that said, I've read the VA's testimony. I know VA recommends some changes to the bill text. I welcome amendments and working with the subcommittee and its members to make this legislation stronger so we can save more of my fellow veterans' lives from the scourge of veteran suicide. Madam Chairwoman, thank you for your time and engagement. I yield back.
Thank you very much, Representative DeLuzio. The chair now recognizes Representative Underwood for 3 minutes.
Thank you, Madam Chair. As a nurse, I'm really proud to be here to testify before you today on one of the first bills that I introduced in Congress with my friend Senator Duckworth, the Copay Fairness for Veterans Act. While I currently sit on the Appropriations Committee, I had the honor of serving on the House Veterans Affairs Committee in the 116th and 117th Congresses. Our veterans are heroes who have given so much to our country, and serving veterans and their families is one of the greatest privileges we have as members of Congress. At a time where research shows us that veterans face worse health outcomes than the general public and have higher burden of chronic diseases, no veteran should go without the ready access to preventive health care services that can improve their health care and quality of life. That's why my legislation would eliminate, once and for all of the financial barriers that can prevent veterans from accessing basic care. Under the Affordable Care Act, almost all private health insurance plans are required to provide coverage of preventive services without charging copays. However, while most civilians have been able to access preventive services without copays for nearly 15 years thanks to the ACA, This same guarantee does not exist for our veterans, at least who get their health care through the VA. Despite their sacrifices and commitment to our country, veterans are still at risk of being charged out-of-pocket costs for services like cancer screenings, mammograms, diabetes care, and screenings for depression and anxiety. That is just unfair, but luckily, friends, we can fix it. My Copay Fairness for Veterans Act rights this wrong by eliminating out-of-pocket costs for veterans seeking the preventive services that they need and deserve at the VA. My bill will ensure that veterans are not charged copays for basic essential care, such as screenings for cancer, depression, anxiety, diabetes, and other diseases, interventions to prevent and treat heart disease, maternal health care and breastfeeding support for new moms, help with alcohol and tobacco abuse, well woman visits, and other critical healthcare services for veterans and their families. I'm proud to say that this bill is endorsed by the Disabled American Veterans and the Minority Veterans of America, among others. Our veterans have earned the best, and I urge my colleagues on both sides of the aisle to support this critically important legislation. So thank you, Madam Chair, for including this bill in today's legislative hearing, and thank you to our witnesses for being here. I yield back.
Thank you, Representative Underwood. As is our practice, we'll forego a round of questioning for the members. For those off-committee members, you may stay around to ask questions of the witnesses if you have time. Our first panel is already at the table. Thank you. Joining us from the Department of Veterans Affairs is Dr. Thomas O'Toole, the VA's Deputy Assistant Undersecretary for Health and Clinical Services for Quality and Field Operations. He's accompanied by Dr. Antoinette Chappelle, VA's Deputy Assistant Undersecretary for Health and Patient Care Services, and Dr. Thomas Immendorfer, VA's Executive Director of Pharmacy Benefit Managers. Also on our first panel, we have Dr. Jeffrey Gold, President of the University of Nebraska Health System. Welcome, Dr. Gold. Dr. O'Toole, you're now recognized for 5 minutes to present the department's testimony.
Great, thank you, and good afternoon, Chairwoman Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee. Thank you for inviting us here today to present our views on several bills that will affect Department of Veterans Affairs programs and services. Joining me today are Dr. Antoinette Chappelle, Deputy Assistant Undersecretary for Health for Patient Care Services, and Dr. Thomas Immendorfer, Executive Director of Pharmacy Benefits Management. I joined the VA 19 years ago, leaving a senior position at a large academic health center to work at the VA hospital in Providence, Rhode Island. The surge in deployments needed for the Iraq War was underway. We were seeing more and more veterans returning from the war needing our help. And it's a decision I have never regretted. I've been incredibly proud to work in the VA. Our commitment to mission, the professionalism and dedication of my colleagues, and the excellence in care and quality that VA provides to our nation's veterans defines us as an agency. Much of this has come from the strong partnership, guidance, and oversight we receive from Congress, and the thoughtfulness and intent of the legislation being discussed today reflects that. While the department views are provided in detail in written testimony, I would like to highlight several bills in my opening remarks. The No Wrong Door for Veterans Act makes several amendments to the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. VA strongly supports the intent and some of the amendments the bill would make, particularly extending the program through fiscal year 2028 and requiring grantees to inform individuals about emergent suicide care. However, we do have concerns about some of the bill's amendments and look forward to working with the subcommittee to address those further. This bill aligns with the department's priority of reaching veterans at risk for suicide. VA also supports the Standardizing Treatment and Referrals Act, or START Act. This bill ensures that the referral period for care from a non-VA provider begins on the date of the first appointment. VA supports this bill. However, we would like the opportunity to work with the subcommittee to ensure the text is clear and doesn't result in any unintended consequences. The VA strongly supports, we all support efforts to reduce veteran suicide. However, in its current writing, we do not support the Saving Our Veterans Lives Act. As written, the bill is overly broad and the resources needed to implement would significantly exceed the authorized appropriation of $5 million per year. VA supports with amendments the Women Veterans Cancer Care Coordination Act and the Veterans Supporting Prosthetics Opportunities and Recreation Therapy Act. VA supports H.R. 217, the Chip In for Veteran Acts, which would allow VA to modernize infrastructure more efficiently and cost-effectively. VA supports efforts to ensure veteran state homes are adequately supported in covering the costs of care for veterans. Though we do not support the Providing Veterans Essential Medications Act, we would appreciate the opportunity to discuss this bill and VA's concerns with the committee. VA supports the Co-Payment Fairness for Veterans Act with amendments and subject to appropriations. Regarding the Veterans National TBI Treatment Act, this bill requires VA to implement a pilot program for hyperbaric oxygen therapy, or HBOT, for veterans with TBI or PTSD. VA does not support this bill due to the lack of scientific evidence supporting HBOT for these conditions, and we have concerns about the proposed funding mechanism. VA does not support H.R. 658, Qualifications for Marriage and Family Therapists, and we defer to the Comptroller General regarding H.R. 1823, directing VA and the Comptroller General to report on certain funding shortfalls in VA. Finally, VA does not have views on H.R. 1107, Protecting Veteran Access to Telemedicine Services of 2025, and we will provide these views in a letter to the subcommittee after the hearing. This concludes my statement. We appreciate the continued support and oversight of the committee. My colleagues and I are prepared to respond to any questions you or other members of the subcommittee may have about the legislation before us. Thank you.
Thank you, Dr. O'Toole. The chair now recognizes Dr. Gold for 5 minutes.
Thank you and good afternoon, Chairwoman Miller-Meeks, Ranking Member Brownlee, and other members of the committee, and Congressman Bacon. I'm Dr. Jeff Gold, and I have the distinct privilege of serving as the president of the University of Nebraska system, which has campuses in Lincoln, Omaha, and Kearney, as well as a top-ranked academic medical center in Omaha. We educate approximately 50,000 students and do approximately $700 million in peer-reviewed medical research. I myself am a recovering pediatric heart surgeon by training, but for the last 10 years prior to my current position, I had the privilege of serving as the Chancellor of the University of Nebraska Medical Center. For many decades, UNMC, the University of Nebraska Medical Center, has had a broad and deep relationship with civilian and military federal departments focused on training, research, and clinical care. However, over the past decade, there's been intense multi-departmental focus with key partnerships in civilian and military CBR&E global health security challenges. Thank you for the opportunity to testify today to support Congressman Bacon's H.R. 217, which seeks to make permanent the Chip In for Veterans Act. This bill supports our service members through innovative approaches to develop and finance VA facilities through public-private partnerships. Since 2016, Congressman Brad Ashford of Nebraska and Senator Deb Fischer were instrumental in passing this new legislation, creating this pilot program that allowed public-private partnerships with the VA. This opportunity led to remarkable improvement in care for local veterans in our community, including the construction of a new ambulatory center that today serves as a key resource for outpatient diagnostic, procedural, and interventional veterans cares and services in the Nebraska, Western Iowa region. This project was funded through federal dollars and private philanthropic support and has been recognized nationally as a true pillar of success. However, at this time, the University of Nebraska Medical Center, my organization, has identified a significant need to replace several of our own aging academic facilities on the Omaha campus, and among these is a forthcoming $2.19 billion project known as Project Health. This will serve as a state-of-the-art medical facility with unique training opportunities focused on meeting Nebraska's growing need for medical professionals. This project will also provide access to high-quality advanced medical care, a unique interprofessional multidisciplinary learning environment, and access to life-saving clinical trials for patients across the state and in the region. Project Health is a collaboration of the state of Nebraska, the city of Omaha, the University of Nebraska, the Academic Medical Center, and of course, Nebraska's philanthropic community. We have proposed that the replacement local VA hospital now be positioned on the UNMC campus to better meet the needs of veterans in Nebraska and western Iowa. This would be constructed to replace the aging facility currently in use. This new freestanding facility would be branded, staffed, and operated by the VA with physical connectivity to Project Health for potentially shared diagnostic, interventional, laboratory, and support services. This would also provide proximity for university clinicians and learners from UNMC, and also remain open to staffing and training for other public and private academic medical center professional staff. Leveraging private construction and adjacent resources significantly creates more cost-effective facilities and opportunities for renovating and replacing the existing VA hospital that was opened in 1950. Our approach is not only cost-effective, but also ensures veterans receive the highest standard of care by utilizing private sector efficiencies and philanthropic support. We can significantly reduce construction timelines and costs, ensuring timely delivery of quality services to those that have served our country. Our community has demonstrated the potential of highly successful public-private partnerships in veterans health care in the CHIP-In Act, born in your committee. This is just one example of proven success. By effecting the proposed partnership in Omaha, we together can set the standard for future care for those that have worn the cloth of our nation and protected our freedom. I thank you for your time and look forward to your questions.
Thank you, Dr. Gold. The chair now recognizes General Bacon for 3 minutes to speak on his bill, H.R. 217.
Thank you, Madam Chair. I appreciate the opportunity to advocate on this bill in the subcommittee, and the bill is H.R. 217, Communities Helping Invest Through Property and Improvements Needed for Veterans Act, otherwise known as the Chip-In for Veterans Act. This bill will make the current pilot program permanent. So Chairman Boss has been out to our district and seen the new facility. I appreciate that Chairwoman Miller Meeks has been out there. I invite the ranking member and frankly anybody that wants to go to Omaha and see literally one of the most beautiful VA facilities in the country. And it was done through this bill that was temporary that we'd like to make permanent. I also want to thank Chairman Gold for being here and Ms. Sue Morris, who helps manage the philanthropic operation here to make this possible. The Chip-In for Veterans Act enables communities to take the lead, contribute resources, and complete VA construction projects on time and in a cost-efficient manner, benefiting taxpayers, the communities, and most importantly, our veterans. The Ambulatory Care Center in Omaha, Nebraska, was the first public-private partnership project for the VA. Now, I'd like to get your attention on this because this is what makes this so important. The VA had budgeted this for $135 million. That was going to be the cost. The community, doing it with state, local financing, and philanthropic, plus federal, was able to do this for $85 million. So right away, we saved $50 million for the taxpayer. It gets even better. Out of that $85 million, $35 million came from not federal sources, philanthropic, state, and local. So in other words, this cost went from $135 million for the VA down to approximately $50 million. And this is why this bill is so important, and we can do this all over the country where folks want to donate and contribute and where states and local governments want to help. So since the doors opened in August 2020, the Ambulatory Care Center has provided cares for 31,744 patients and over 261,000 visits. Now we want to replace the inpatient facility now. And we already have approximately $100 million outside of the VA ready to invest in this facility. It will be a great deal for the VA. So I look forward to working with the committee to enact this legislation and with the Department of VA and the philanthropic community to bring this to fruition, another innovative facility for the benefit of veterans across the country. And I yield back.
Thank you, Representative Bacon. As is my typical practice, I'll reserve my time until all other members have had a chance to ask their questions. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Dr. O'Toole, I'm disappointed that the VA is opposing my bill, the VA Marriage and Family Therapist Equity Act. You know, VA is an outlier among its peers, including TRICARE, in terms of requiring licensed marriage and family therapists to have graduated from a commission on accreditation for marriage and family therapy education program in order to be promoted within the VA. MFTs are among the occupations for which VA has been developing national standards of practice for the last several years. Perhaps you can reconsider this standard as part of that effort if it's still underway under the new administration. Can you share any updates on the National Standards of Practice initiative?
Thank you, Chair. Thank you, Congresswoman. And the national standards work is ongoing. The intent behind that effort is to ensure that there is minimized variance across states in terms of accreditation and licensure. The VA is very supportive of the position of marriage and family therapists. We see it as an integral part of the VA. Our primary concern with this is that there are currently no statutory requirements for supervisory roles in any of our Title 38 positions, and our concerns with state variances that currently exist in how those supervisory roles are supported. But we are very open and would be happy to work with the subcommittee further to further advance this legislation in a way that would work, or that our rules would work.
Thank you for that. I mean, I just believe that this kind of clinician is so critically important to the veteran community. And, you know, for a while we didn't even accept marriage and family therapists. Now we do. But in order to keep them, they have to have a road of opportunity to be promoted. And I just think it's so many other states, TRICARE, so forth, does not require this. It requires another accreditation, and it works pretty well. So anyway, I hope that you will continue to consider it, because I think it's really, really important. The next question I had is I wanted to talk a little bit about the VA and its undertaking to expand access to lockboxes and other suicide prevention tools for veterans. I think Mr. DeLuzio's bill is a good one, and I think we need to strengthen those efforts. But can you sort of expand on the lockbox distribution program that you're already providing?
Thank you, Congresswoman. And to begin, we very much share the concerns about the need and the essential capacity of, we have to be there to reduce veteran suicides. And I can speak personally to having had patients who have died by suicide. I think all of us know, sadly, individuals who have family members, who have friends who have died by suicide. This is an emergency. Currently, the VA does have a lockbox program. It began last year. It's run jointly between our Office of Suicide Prevention and the Prosthetics Department to provide lockboxes for veterans identified as part of a clinical encounter and clinical screening who are determined to have risk for suicide, moderate to high risk, who have access to firearms or peripheral access to firearms, meaning a member of the family or household has access to firearms, in which case they are provided a lockbox, which is a proven method of trying to create space between the impulsivity of wanting to commit suicide and having access to a lethal means. Our concern with this bill is that—
I'm not asking about the bill. I'm asking about the program and what you're doing. So I want to know, it's my understanding that under the current program, lockboxes have to be requested by their provider. So how would a veteran or their provider know this program is available?
Thank you, ma'am. We have an extensive education experience both to the veteran as well as to the provider to promote this program to both groups to try to encourage its application and use.
Okay, so we know it's a good program. You've already said that it is a good program. And I just, it seems to me that making sure that any veteran who wanted a lockbox should receive a lockbox, because there are many veterans out there where we might not know their situation or their vulnerabilities. So I think it's important to do that. And I guess what kind of, oh, I've run out of time. I yield back, Madam Chair.
Thank you, Representative Brownlee. The chair now recognizes Representative Hamadeh for 5 minutes.
Thank you, Chairwoman. As an Army intelligence officer who's served overseas, I understand firsthand the obligation we have to those who wear our uniform. And our veterans deserve more than gratitude, they deserve action. That's why I'm proud to support several of the bills before us today that will directly improve healthcare access and quality of life for veterans all across Arizona and our country. And my first question is for Dr. O'Toole. The alleged budget shortfall within the VA raises serious concerns about your organization's financial planning and resource allocation. Do you believe the VA should undergo an annual forensic audit?
Thank you, Congressman. And first, I just want to say thank you for your service in the military as well as here with us today. So on this particular bill, we do defer to the Comptroller General.
And what is their recommendation?
So by deferring, we are deferring to the Comptroller General on the forensic audit.
But do you believe that having a forensic audit would give confidence to veterans and the taxpayers that their money is being spent wisely?
Yeah, do appreciate the question, Congressman, but we would defer to the Comptroller General.
Dr. O'Toole, the Parker Gordon Fox Suicide Prevention Grant Program has helped expand access to mental health care for veterans. In what ways has the program been most effective, and how can it be further improved to ensure veterans in crisis receive timely mental health care?
Thank you, Congressman. This act has been serving our veterans very well, and we support several of the amendments that are in the bill. The grant program in particular, we have found very helpful and has been very supportive. 4 of the amendments in particular we are supportive of, including the extending the duration of the pilot program because of its successes, requiring grantees to inform individuals about their ability to receive emergency suicide care, which we currently do, but I think codifying it is going to be a strength. Ensuring that eligible entities have provided mental health care and support for veterans support services in the U.S. for the previous 2 years, we feel strengthens it. And there's some technical corrections as well we support. The concern we have with this bill is the $500,000 cap and the $10,000 per grantee additional payment, which we think would be difficult logistically to manage in the context of how federal grants are currently managed with providers in that form.
Thank you. And going off of Congressman Bacon's comments earlier, it is a very impressive facility from what I see, and I'd like to visit that, Congressman. And my third question is to Dr. Gold. What were the biggest advantages of using the public-private partnership for the Omaha Center project, and how can this model be replicated across the country?
Well, thank you for asking, sir, and of course, thank you for your service. There are so many different advantages. One was to, of course, save a lot of money. And so what could have cost the VA $136 million ended up costing $56 million out of the VA. Secondly, this project was finished not only exactly on budget, but ahead of schedule, which doesn't always happen in large federal construction projects. At least that's been my multi-decade experience. But it also was able to bring to bear the experience that our university had with being part of this small but very effective 501c3 corporation, in that we had built lots of different healthcare facilities, ambulatory care centers, ambulatory surgery centers, and many other things women's health centers, imaging centers, et cetera. So being able to bring all that to bear with the architects, the engineers, and with the construction contractors allowed us to accelerate the planning for the process in partnership with a local VA and deliver it on time and on budget.
Yeah, truly, truly impressive project.
And
that
it
you
is
guys
a
undertook.
beautiful facility, an
Right.
award-winning facility.
On time and under budget. It's pretty rare for the federal government. I yield back.
Like $85 million under budget.
Thank you very much, Representative Hamadeh. The chair now recognizes Representative Sheriff Phyllis McCormick for 5 minutes.
Thank you so much. I would first like to say thank you to our panelists for testifying today and for your dedication and service. Dr. O'Toole, Representative Garcia's Women Veterans Cancer Care Coordination Act identifies the difficulties veterans face in navigating transitions to and from community care. For instance, I've heard of cases where medical records from community providers took weeks to return, delaying crucial treatment and causing unnecessary stress for the veterans and their families. No veteran should navigate their battle with cancer alone. Dr. O'Toole, do VA hospitals need dedicated community care coordinators, teams to help veterans navigate and keep contractors accountable?
Thank you, Congresswoman. And first, we agree with you absolutely. No veteran, no person should have to navigate the management of cancer by themselves. And we strongly support the role of care coordinators in helping them both navigate the care within the VA and navigating the care in the community.
What is the impact to the veterans' care when there is not a seamless through line between community care and the VA?
The biggest challenge, Congresswoman, I think, as we would all acknowledge, is the concern about care falling through the cracks, not being communicated well to different providers who are involved in that care. For the veteran, not knowing what was going on with their care. And these are things that nobody should have to experience in their care journey.
Dr. O'Toole, my second question, having a regional breast and gynecological cancer care coordinator for each VISN has the potential to save many lives. If Representative Garcia's bill were to become law, however, I have deep concerns that DOJ may work to stop this position from being in existence. Over the weekend, the New York Times uncovered a horrifying consequence of DOJ's indiscriminate workforce cuts. The VA hospital employees responsible for enrolling veterans with throat cancer in an NIH clinical trial was fired. As a result, the clinical trial was put on hold, and veterans with cancer were left without access to potential life-saving medication. Dr. Gold, should we exempt clinical trial coordinators in the coordinator position established by the Women Veterans Cancer Care Coordination Act from DOJ's indiscriminate firing?
Well, there is no question that access to clinical trials is life-saving, particularly in cancer, but also in end-stage congestive heart failure, in neurodegenerative diseases, and so many others. And our veterans should be afforded the very best quality care that our nation can provide, which means they need to have access to all of those trials. In order to do that, we must have qualified personnel to enroll and to perform those trials and to monitor them.
So you would recommend expanding the exemption to other areas and other positions also?
Again, the access to clinical trials is absolutely state-of-the-art, and it needs to be available to all in our nation.
Do you believe VA's plan to lay off 83,000 workers will help facilitate veterans' access to cancer care?
I know that the staffing of any medical center, large or small, is what makes it work. The buildings are beautiful, the coffee shops are important, but at the end of the day, it's the doctors, the nurses, the pharmacists, the therapists that make it all work. And I also know that you need a critical mass of that workforce to make it successful.
So is that a yes or a no?
Do you mind repeating your question?
Do you believe that VA's plan to lay off 83,000 workers will help facilitate the VA's access to cancer care?
Without understanding the details of which 83,000 workers would be laid off, it's difficult to give you a specific answer, but anything that materially reduces the workforce will materially reduce access to care and quality of care.
So I'll take that as a yes. Well, thank you. I'd like to note that the VA research has led to the best treatment in the world when it comes to prosthetics, spinal cord injuries, and TBI. In addition, VA researchers also brought use of the pacemaker, nicotine patches, and aspirin as a method to preventing heart attacks. Attacks on these healthcare researchers and the VA affects every veteran in America, not just the veterans who are presently receiving care. Thank you so much for your time, and I yield back.
Thank you very much, Representative Sherfless McCormick. The chair now recognizes Representative King Hines for 5 minutes.
Thank you, Madam Chair. My question is to Dr. O'Toole. So I come from the territories, and I just wanted to get your thoughts. Given that the Parker Gordon Fox Suicide Prevention Grant Program is designed to reach veterans who may not necessarily be engaged with the VA, how is the program ensuring that the resources are effectively reaching veterans in remote or underserved areas, such as U.S. territories like the CNMI?
Thank you, Congresswoman, and that's obviously of great importance. I think the intent and design of the grantee process is critical to that, to ensuring, and both also our monitoring of grantees to ensure that that is appropriately managed and distributed to every veteran, no matter where they live.
So, okay then, so in addition to that question, what strategies are in place to support community-based organizations in these areas that may lack the infrastructure or capacity to apply for and manage these grants effectively so that we do meet the mission of serving our veterans, especially in underserved remote areas?
Thank you, ma'am. I'd have to take the specifics of that response on the record and defer to our subject matter experts in that program. It's something, though, we fully agree with in terms of its importance.
Thank you. I appreciate that. I yield my time, Madam Chair.
Thank you very much, Representative King Hines. The chair now recognizes Dr. Dexter for 5 minutes.
Thank you, Chairwoman Miller Meeks, and thank you to our witnesses for being here today and for your service to our veterans. And although I'm very grateful for the opportunity to consider this legislation before us today, I have to state the obvious. We are proceeding with business as usual when nothing about what is happening in the world is business as usual. In a matter of hours, everyone on this dais will leave this room to vote on legislation put forth by my Republican colleagues to cut nearly $23 billion in advance funding to ensure we can care for our veterans exposed to toxic chemicals in the line of duty. And if that weren't bad enough, that vote comes just days after we found out that Trump's team will fire an additional 83,000 VA workers on top of the 2,400 they have already stripped of their jobs, and return us to the staffing levels we saw before implementation of the PACT Act, the biggest expansion of veterans' benefits in generations. Make no mistake, these firings are as good as a cut for veterans. Without those dedicated workers, our veterans will absolutely have trouble accessing the care and benefits they have earned, waiting longer for their claims to be processed, or worse, not being able to access new benefits at all. Look, I built a track record at the state level for being able to reach across the aisle. I absolutely want to get things done, but several of the bills before us are good policy, whether it's ensuring veterans have access to essential medicines, regardless of where they're cared for, improving care coordination for women veterans, or advancing cost-effective gun safety measures. But I have serious doubts about our ability to implement any of these policies if the VA doesn't have the staffing or the funding that it needs. I spent much of my professional career practicing as a physician at Kaiser Permanente in Oregon and served first as a board member and then as chair of the board. So I understand intimately the challenges of running a large medical system. So I simply have a simple question for you, I hope, Dr. O'Toole. First, would it make it easier or harder to implement a new initiative at the VA if it were uncertain that the VA would be provided with the funding required to do so?
Thank you, Congresswoman. And excuse me, I'm trying to fully, I guess, understand the question. Obviously, any bill that comes through, it helps to have the authorizations associated with that bill to be able to implement it.
Okay. Thank you. And would it make it easier or harder to implement a new initiative at the VA if there were no staff to do so?
Thank you, Congresswoman. And again, I think I'm not, I would have to take for the record specifics related to, current issues related to staffing and the staffing proposals underway. I think in general, though, I think that your question is rather self-obvious, though.
Thank you. And following up on my colleagues' questions regarding care coordination, do you have objective reasons to believe that care coordination within the VAMC, especially around cancer care, is superior to care outside coordination with our community care systems?
I would need to defer to our subject matter experts who have spent, many of them have spent their careers studying differences in quality between the VA and care outside the VA. I've been very proud to be a clinician in the VA system and very proud of the care that we provide and the outcomes we provide. It is not to say we could never do better. We always can. I think the role of care coordination, particularly in complex care that involves multiple providers, it's been well proven to be an important element of that care.
I absolutely agree with you, having had access to care coordinators throughout my practice as well on lung cancer treatment. I'm going to ask, Madam Chair, if we can submit some studies for the record looking at the comparison of outside versus inside care, one of which is titled VA Delivered or VA Purchased Care, Important Factors for Veterans Navigating Care Decisions.
No objection.
Thank you. I just urge my colleagues to keep in mind the importance of this legislation. I certainly appreciate the work that folks are doing, but that we can't expect better care when we got the system that has to deliver it. And with that, I yield back, Madam Chair.
Thank you very much, Dr. Dexter. The chair now recognizes Dr. Conaway for 5 minutes.
Thank you, Madam Chair, and thank you. Thanks to our witnesses for presenting themselves to us today and offering information on the bills at hand. Mr. O'Toole, this question is, I think, directed at you. You're taking most of the incoming now, it seems. But in the last Congress, the No Wrongdoer Act was introduced to demonstrate improvements in veterans' mental health, a very critical issue we're seeing. Sadly, the number of suicides among that cohort going up. The updated version has changed that requirement that now grantees must show that funds are being used to assist a significant number of veterans. So my concern is that went from showing that you have good outcomes to showing that you have, quote unquote, significant numbers of veterans who are receiving assistance. And so the question is, what does significant mean in that context? How do we measure it? When do people meet the bar?
Thank you, sir, and that reflects similar concerns that we have to the construct of this bill. Absolutely, these pilot programs have made a difference, and we are strong supporters of them. The bill as drafted in changing from the $750,000 grant amount to $500,000 with an additional $10,000 per individual served, we feel would create challenges and logistics to both how the grant would be administered, but also challenges to how we would be assessing performance of those grants. We stand very much in support of this legislation and the intent of it, but I think we share the subcommittee's concerns and try to make sure we have the best bill going forward.
I agree with you. The effort is more than worthwhile considering what we're seeing among the veterans community and indeed mental health more broadly, but certainly we have a particular need and duty to provide that care to those who've given so much to our country. Next, I want to address H.R. 1336, the Veterans National Traumatic Brain Injury Treatment Act. This bill aims to direct the Secretary of Veterans Affairs to establish a pilot program to provide hyperbaric oxygen therapy to veterans suffering from traumatic brain injuries or post-traumatic stress disorder. And indeed, we have seen studies in the traumatic brain injury space which suggests that the use of hyperbaric oxygen therapy would be really quite beneficial. And so The VA conducted its own study, and it showed great promise. Does the VA have any reservations regarding this pilot program and the potential impact of this therapy on veterans?
Thank you. Thank you for your question. VA shares your concerns. Mental health and suicide preventions are huge priorities for VA. We do not support this bill. Our VA subject matter experts are continuously reviewing scientific literature and updating and publishing our clinical practice guidelines. Published results of the scientific rigorous research that has been done by VA and DoD repeatedly have shown the hyperbaric oxygen therapy has the same impact as placebo.
What's that? Say that? If you would speak into the mic, it would be very helpful.
Published studies.
There you go.
Published results of the scientifically rigorous research that has been done by both VA and DoD has shown repeatedly the hyperbaric oxygen therapy has the same impact as placebo. There's no scientific basis to support the use of hyperbaric oxygen therapy for PTSD, and there is strong scientific basis that hyperbaric oxygen therapy is not recommended for traumatic brain injury.
We're looking at a study here on our desk that would suggest otherwise. It is an NIH study, and certainly we do want to look at the preponderance of evidence across multiple studies that are done, hopefully, according to the most rigorous standards. Could you therefore, if you don't like the hyperbaric oxygen as a treatment, could you suggest that alternative therapies that we're perhaps not using now that ought to be deployed to deal with these important conditions?
Thank you. Yes, as I mentioned, our subject matter experts are continuously reviewing scientific literature. I'd be happy to provide you a review of other alternate therapies that we are currently considering.
Great. Thank you, Madam Chair.
Thank you, Dr. Conaway. I now recognize General Bacon for 5 minutes for any questions he may have.
Thank you, Madam Chair, for the opportunity to be part of your subcommittee today. I'd like to follow up with President Gold on some of his comments on the numbers, because I think they're worthy of repeating. What he said is that the VA, we saved the VA or the federal government approximately $80 million. What was going to cost the VA $135 million ended up costing the federal government $56 million. I think I got the numbers that you said right there. Chancellor or President Gold, could you lay out what can we expect for the inpatient hospital? Rough numbers, like what does the federal government or the VA think it's going to cost versus what we could probably build it at versus how much state and local and philanthropic money we may get? I want to show the benefit of this for our future facility.
Well, a lot would depend on, first of all, it's a great question, one we try to deal with as best as possible. A lot would depend upon how much shared services we're talking about. Certainly replacing inpatient, med-surg, critical care, and other bed space would be essentially at the standard construction rates for large academic medical centers, high-quality academic medical centers. However, a lot of the cost of construction in healthcare now really is not on the inpatient bed space, but it's in the extremely expensive diagnostics, procedural, interventional space, biplane fluoroscopy, for instance, some of the modern laparoscopic and endoscopic operating rooms, et cetera. Even in the ophthalmology world, the equipment has gotten incredibly expensive with the operating microscopes and things like that. So the extent that some of that space could be shared, some of the clinical and anatomic pathology space, some of the diagnostic space, some of the even some of the outpatient space that would need to be connected, shared parking, shared logistics and infrastructure. I mean, right now the project is on the VA construction list as, I believe, #2 priority for 2029 at, if I'm correct, at $1.56 billion. And I would venture to say that we could probably save the federal government if we did this in a shared fashion and shared these types of resources. I bet you we could shave $500 million to the taxpayers.
That's what I was waiting to hear.
Well,
that's the savings right there.
How much is saved?
If I may ask our VA representatives, and I'll defer to which one, could you talk about what this chip-in bill has done, what it means to you? Love to get your perspective on this.
Thank you, Congressman, and I think we're adding to the chorus. VA supports this bill. As you know, were authorized as part of the pilot for up to 5 projects. 2 have been undertaken, 1 completed in Omaha, as you've heard, and a hospital in Oklahoma is currently under construction. We do support this legislation.
With that, Madam Chair, I yield back.
Thank you very much, General Bacon. I now yield myself 5 minutes. I'm going to follow up on something Dr. Gold said, which is carrying the public-private partnership even beyond, i.e. sharing facilities, especially those expensive facilities and sharing parking. And some people may be aghast at that. But Dr. O'Toole, don't many VA hospitals, aren't they staffed by people that have dual appointment between a medical center and a VA center?
Thank you, Congressman. Yes, actually, we have a very deep academic partnership and footprint, and particularly in our level 1A, 1B, and C facilities. And I would note that 70% of doctors practicing in the United States all went through a veteran hospital as part of their training.
As did I. Dr. Gold, the Omaha VA Ambulatory Care Center was completed a year ahead of schedule and over $40 million under budget, thanks to the Chip-In for Veterans pilot program. How did the VA's Chip-In authorities foster such a successful public-private partnership?
Thank you for the question. I think one of the biggest advantages that we shared was that we were able to plan this the way we would plan a commercial, large academic medical center clinic and then deliver it on a schedule that we would normally do it. Over my decade of leadership at the University of Nebraska Medical Center, we've done over $1 billion of healthcare and academic construction, and have never exceeded the budget, and have really never exceeded the timeline. I mean, the construction standards are absolutely critical because of the penalties associated with going over budget and going over timeline. And anybody that has been involved with large academic medical centers understands that time is money for all of these types of projects. And that type of precision was used through the 501c3, and you'll hear from Sue Morris in a little bit about how that actually worked. But that type of precision was used in a very, very careful way to be sure we delivered this project.
Thank you, and it's one of the reasons we're hoping to make this permanent. And for those who are interested, there's a pamphlet here that shows that clinic. It's quite outstanding. Dr. O'Toole, the Parker Gordon Fox Suicide Prevention Grant has made tremendous progress in connecting veterans with timely mental health care in their communities. Why is it vital that we quickly reauthorize the program?
Excuse me while I catch up to my notes here on this. Thank you, and yes, we fully endorse the importance of this. My understanding is that the concern is obviously being able to reauthorize it before the pilot project expires, which my understanding is September 30th, 2028. And we strongly endorse this legislation as an important armament in our effort to reduce veteran suicide. So we thank Congress definitely for all of your work and support on this effort.
And then again, Dr. O'Toole, the START Act would ensure community care referrals remain valid through the veteran's standard episode of care. Would this help veterans receive all the care that the VA has determined necessary?
We think so, ma'am, and I think this is an important element where this legislation will help the VA practice to its policy. Obviously, our intent is obviously ensuring that it's not just the episode of care or the first appointment, but rather the episode of care, which can be up to 1 year and renewable beyond that. And more importantly, it's about helping the VA, I think, shore up its practices to ensure that we are doing a better job of ensuring that that is actually what we are practicing to.
Yeah, and I think, Dr. Gold, you were asked a question that may be difficult for you to answer. It was in letting people go and managing a very large healthcare facility. Let me just say that if you were given an increase in your budget by $126 billion over a 4-year period. And over that same past 4 years, you had an increase in full-time employees of 60,000 and part-time employees for 23,000. And you were looking at 80,000 employees, exempting hiring of nurses and doctors. Would you consider that gutting a program?
I guess it would depend on the role of those individuals. You know, having been a pediatric heart surgeon for over 2 decades of my life, it's not just the person that stands at the operating room or over the ether screen, but it's the person that mops the floors and stocks the supply cabinets and does so much else within our system.
So you would need to know what those positions are. Thank you so much. With that, I yield back. I'm going to ask if we would have our, on behalf of the subcommittee, I want to thank all of our witnesses for their testimony and joining us. You're now excused. We're going to wait a moment while the second panel comes to the witness table. Welcome, everyone, and I thank you for your participation today. On our second panel, we have Ms. Sue Morris, President and CEO of Veterans Trust, Mr. Brian Dempsey, Director of Government Affairs for Wounded Warrior Project, Dr. Andrew Kosminski, Medical Director of Hyperbaric Medicine for the University of Iowa Healthcare, Mr. Ed Harries, President of the National Association of State Veterans Homes, and John Retzer, Deputy National Legislative Director for Health, Disabled American Veterans. Ms. Morris, you're now recognized for 5 minutes.
Good afternoon, Chairman Miller Meeks, Ranking Member Brownlee, and members of the Health Subcommittee. My name is Sue Morris. I am the President of Veterans Trust, the nonprofit philanthropic entity that partnered with the Department of Veterans Affairs under the CHIP-In Act to construct VA's Ambulatory Care Center in Omaha, Nebraska, serving Western Nebraska, Western Iowa, and Nebraska. Our nationally award-winning Ambulatory Care Center project was completed and donated to Veterans Affairs in July 2020 as the first public-private partnership to be completed under the CHIP-In Act. The project received several national awards for healthcare design and construction. I'm here today to speak in favor of taking the pilot program authorized under the CHIP-In Act and making it permanent as H.R. 217 would do. Our project showed how VA, in partnership with the private sector, delivered a truly superb facility in a cost-effective and efficient manner. What allowed the Omaha project to be successful? First, the project was owned by Veterans Trust during the development and construction phases and then donated to Veterans Affairs upon completion. While there was very close coordination and cooperation between Veterans Trust and VA officials at both the national and local levels, it was not a government construction project. This structure allowed Veterans Trust, whose leadership had a history of facilitating over $1 billion on local projects, to use local vendors and suppliers in its procurement of services and materials, leveraging demonstrated relationships for best pricing. We were able to tell our partners in design and construction that they will make money on the project, but not a lot of money, as this is a community project to serve our veterans. Second was a strong commitment from Veterans Affairs senior leadership. We met regularly at VA headquarters, including 3 meetings directly with the Secretary to ensure project milestones were achieved. There was 0 scope creep, which helped the project to be delivered on time and on budget. One key factor in this regard was Veterans Affairs' willingness to review VA's normally applicable construction and physical security standards. We were able to come to agreement on which of those standards made sense, resulting in value-engineered savings of $23 million. In the end, we delivered a facility for a total of $86 million when it was originally budgeted at $135 million, saving the taxpayers $50 million. In addition, the private philanthropic contribution to the project was $30 million. Based upon our experience and success with this effort, we recommend that H.R. 217 go further than simply making chip-in permanent, to also to consider other changes. In particular, we suggest the following. Add the option to construct facilities on land leased to VA, not just owned or donated real property. Add the ability to use the program for minor construction, not just major projects. And make clear that the Act applies to more than just health care, but also to construction projects providing other types of facilities to veterans, such as housing and community centers. In amending to the Act itself, we suggest the subcommittee and staff engage a small group of VA leadership and private sector representatives to recommend forward-looking best practices and new models for public-private partnerships. My team and board would be pleased to be included in this effort. In summary, we wholeheartedly support the effort to make chip-in a permanent tool to deliver state-of-the-art facilities. The Act allows Veterans Affairs the ability to leverage advantages of private sector construction processes to deliver significant cost savings. We are tremendously proud of our role in helping lead in this effort to deliver a world-class facility to our veterans and cost savings to our taxpayers. I want to add one final point. As Dr. Gold mentioned, there is no doubt that a new inpatient facility to replace Omaha's aging VA hospital is sorely needed, as in other cities. Veterans Trust stands ready to partner with Veterans Affairs and the University of Nebraska Medical Center to assist in developing a new state-of-the-art inpatient facility that will better serve the veteran community. I'm happy to answer any questions that you might have. Thank you for including me today.
Thank you, Mr. Dempsey. You're now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished Health Subcommittee members, thank you for inviting Wounded Warrior Project to testify on legislation intended to improve VA's ability to provide better access to care and ensure better health outcomes for our nation's veterans. Over 20 years ago, when the first wounded service members returned from the battlefields of Iraq and Afghanistan, the founders of our organization made a promise to be there for these warriors no matter what. In the years since, our organization has grown to provide more than a dozen programs and services to more than 227,000 veterans and service members, and our reach continues to grow by the day. These programs and the relationships we've built with warriors along the way are what inform our advocacy before Congress. Today, I'm pleased to speak on 3 bills from the agenda that we believe will have the biggest impact on those we serve. First, we strongly support the Veterans Sport Act. This bill would amend VA's legal definition of medical services to clarify that the agency's existing ability to provide artificial limbs includes the authority to provide adaptive prostheses and terminal devices for sports and other recreational activities. If you're unfamiliar with what an adaptive prosthesis or terminal device is, think of the curved-shaped blades you might see on someone who has lost a lower limb, or a waterproof fin that allows someone with an upper body prosthetic to swim in a pool. Now, think about stress relief you may know from running, the community you found playing in a local softball league, or the body transformation you may have seen from lifting heavy weights. Participating in activities like these should be simple, but for veterans who use VA for prostheses, it can be a challenge. Under current law, and stated as simply as possible, veterans often struggle to get this kind of prosthetic support if they are not actively pursuing a rehabilitation plan, even if they've completed one in the past and are very familiar with what they need to do what they want. VA's regulations focus on the clinical need for adaptive prosthetics, but disregard their potential to improve a veteran's quality of life. And if a clinical need can't be found, providers can't offer the equipment. The Veterans Sport Act would help these veterans by effectively removing the requirement that they be enrolled in a VA rehabilitative program in order to receive the adaptive prosthetics for sports and recreation. The current population of post-9/11 veterans is young, mobile, and energetic. We believe that VA should be building an ecosystem of care that encourages an active lifestyle and makes it easier to experience the profound health benefits, both mental and physical, provided by sports and other recreational activities. Second, we support efforts to renew the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Pilot Program, including the No Wrong Door for Veterans Act. Our organization's approach to mental health care appreciates that no one organization and no single agency can fully meet all veterans' needs. Evidence-based mental health treatment absolutely works when available and when pursued, but the best results will be found by incorporating a public health approach focused on increasing resilience and psychological well-being. This kind of suicide prevention strategy embraces upstream prevention efforts like helping with case management, peer support, outreach, and establishing financial wellness, all of which are recognized as suicide prevention services under the Fox Grant Pilot Program. In each year since the Fox Grant Pilot was launched, VA has discussed it as a key initiative for helping prevent suicide in its National Suicide Data Report. Previous congressional oversight and legislative hearings have revealed that the pilot program is not perfect, but we appreciate efforts like the No Wrong Door Act that would continue to refine the pilot's operation and foster community collaboration in ways tailored to local needs. We hope that this legislation can be prioritized as a vehicle for bipartisan, bicameral action to renew this program in time to disperse grants in fiscal year 2025. Third and finally, we support the Protecting Veteran Access to Telemedicine Services Act. This legislation would extend a COVID-19 era waiver from a law that requires patients to complete at least one in-person visit with a healthcare provider before that provider can prescribe them a controlled substance. If the waiver expires as planned in December 2025, rural veterans who do not live near VA or community healthcare facilities and who rely primarily on telehealth services would likely be negatively impacted. Appointment coordination challenges and travel logistics may lead to interruptions in their care or lapses in prescriptions. The list of controlled substances contains not only pain medications, but also multiple mental health drugs that are important parts of treatment plans for many veterans dealing with mental health issues and for whom an in-person appointment may present additional challenges. Members of the committee, it is my distinct honor to be here on behalf of Wounded Warrior Project to speak to the needs of our nation's wounded warriors and their families. Thank you for letting us do our part to keep the promise. This concludes my testimony, and I look forward to your questions.
Thank you. Dr. Kosminski, you're now recognized for 5 minutes.
Good afternoon, Chairwoman Dr. Miller-Meeks and Ranking Member Brownlee and members of the subcommittee. Thank you for inviting me to participate in this hearing to discuss H.R. 1336, the Veterans National Traumatic Brain Injury Treatment Act. I'm Dr. Andrew Kosminski, an emergency medicine physician with a specialization in undersea and hyperbaric medicine. I am the current medical director for hyperbaric medicine at University of Iowa Healthcare and medical director for the UHC Wound Center. This legislation aims to improve the health of our veterans, establishing a pilot program for the implementation of hyperbaric oxygen therapy for veterans with traumatic brain injury or post-traumatic stress disorder. As an emergency medicine physician, I have cared for numerous veterans suffering from TBIs and PTSD. With my experience in hyperbaric medicine, I think the implementation of hyperbaric oxygen for these ailments would be uncomplicated. Veterans already use this therapy through their VA insurance for currently approved HPO indications. Consequently, HPO, hyperbaric oxygen, has proven its safety after many decades of use by the medical community. For these reasons, this legislation has potential to help improve the lives of our friends, families, and neighbors. I want to comment on the potential for an increased likelihood of oxygen toxicity seizures in this patient population, as 1 in 50 TBI patients develop post-traumatic epilepsy. However, an oxygen toxicity seizure is a complication that trained hyperbaric medicine professionals are well versed in how to manage and should be able to ensure continued patient safety throughout a treatment course. Clinical trials, I will mention, even utilize a protective pressure of 1.5 ATA, which should reduce the likelihood of this complication. However, this is an important reason to create a pilot program through the VA health system, as this would provide a safe option for patients seeking treatment for what is currently an off-label indication. Without this program, desperate patients may find themselves at the mercy of popular health spas. Businesses that might not have adequately trained staff may use incorrect treatment profiles and at times pose serious risk to their patients or their clients. The research that investigators in my field have completed on the utility of HPO for TBI and PTSD shows promise for improving health outcomes in these patient populations. For chronic TBI cases, HPO has been found to improve cellular metabolism, reduce cell death and oxidative stress, and enhance mitochondrial function. These mechanisms aim to promote neuronal repair and regeneration. The Brain Injury and Mechanism of Action, BEMA trial, published in 2016, demonstrated improved post-concussive symptoms, PTSD, cognitive processing speed, sleep quality, and balance function by 13 weeks after 40 60-minute HBO sessions at 1.5 ATA. Unfortunately, these improvements did not persist beyond that 6-month follow-up. In February 2025, however, just last month, Dr. Lindell Weaver, a leader in my field, and his team published their most recent study, a double-blind randomized trial of hyperbaric oxygen for persistent symptoms after brain injury. This study showed similar results to what was observed in the BEMA trial for both sham and HBO groups at 13 weeks, with the HBO treatment group maintaining the neuropsychiatric benefits at 6 months. A second phase within the trial offered another 40 HBO sessions to all participants. At final follow-up, 3 months after the last of the second round of HBO treatments were given, patients who received 80 HBO treatments had greater neuropsychiatric improvement compared to their results after 40 sessions. The patients who received a maximum of 40 treatments also showed neuropsychiatric improvements compared to their baseline scores, but less improvement than their counterparts who received 80 treatments. In conclusion, I find the outcomes of these trials, these clinical trials, to be promising. Establishing a pilot program for the VA to offer HBO therapy for veterans with TBIs and PTSD could help improve these patients' quality of life, provide access to safe healthcare environments in which to receive these treatments, and continue to build insight on how best to construct and administer treatment courses in the future. Thank you.
Recognized for 5 minutes.
Members of the subcommittee, as president of the National Association of State Veterans Homes, thank you for the opportunity to testify today and offer our strong support for the Providing Veterans Essential Medications Act. This legislation would remove an inequity in the law concerning high-cost medications for veterans that are preventing many of them from living in state veterans homes. As you know, state veterans homes are not able to receive reimbursement from the VA for high-cost medications provided to seriously disabled veterans, even though private nursing homes that contract with the VA can. As a result, many state homes are losing hundreds of thousands of dollars every year that could be used to improve the lives of aging and disabled veterans. For example, at the Iowa State Veterans Home, they are caring for a 55-year-old service-connected Air Force veteran who suffers from Crohn's disease. Fortunately, a drug called Stelara can help control his symptoms. However, this medication costs about $20,000 a month, which is more than the full cost of care prevailing rate the VA pays the home. Despite the financial burden, the Iowa State Home decided to care for this veteran at a significant operating loss. However, that likely means that they will have to cut costs elsewhere, perhaps admitting fewer veterans, spouses, or Gold Star parents, or maybe cutting back on social, recreational, or other non-clinical services. The same situation is occurring at state veterans homes across the country. At an Idaho State Veterans Home, a 63-year-old service-connected Army veteran was receiving a medication called Duopa for Parkinson's disease, which costs the home at $16,000 a month. The prevailing rate for Idaho that Idaho receives for this veteran does not fully cost the care of this one medication, let alone the cost of all the other care provided. Unfortunately, due to the financial strain from the high-cost medications, some state homes can only afford to care for a limited number of such veterans with these medications. For example, a 76-year-old 100% service-connected Air Force veteran living in a VA contracted community nursing home in Idaho was taking a special medication called Promacta. The cost of that was $18,000 a month. The VA was providing this medication to the veteran's spouse, who took it to the private nursing home where they would administer it to him. Although the private nursing home was receiving a prevailing rate for the full cost of care, just like the state homes do, their contract included a provision for them to receive or be reimbursed for these high-cost medications. The veteran wanted to move to the state veterans home, and his spouse asked if she could continue to pick up the medication and bring it to the home. The VA told her by law they could not allow it, effectively denying this veteran the ability to live in a state veterans homes, which was his choice. There are also cases where this inequity in the law is literally throwing away money that could be used to improve the care of veterans. In Wisconsin, a 76-year-old, 100% service-connected veteran, a Marine sharpshooter, was admitted to the state veterans homes while receiving chemotherapy medication free of charge through an Astellas patient assistance program. After the veteran moved to the state veterans home, his wife brought the medication so that it could be administered to him. However, according to the VA's rules, they could not use the free medication. The facility itself incurred a cost of $12,000. Wisconsin also had a service-connected Army veteran living in one of their homes who was prescribed a chemotherapy drug by his VA oncologist, which was shipped directly from the VA pharmacy to the state home. When the medication arrived, the home contacted the VA and knew that it could not utilize this because they had not purchased it themselves under the program. When inquiring how to avoid wasting a $20,000 medication, the VA told them it could not be returned, even though it was in its original sealed packaging, and to dispose of it. Madam Chairwoman, the Providing Veterans Essential Medication Act would require VA to furnish and reimburse state veterans homes for these high-cost medications, just like they are doing for the private homes. This would ensure that the veterans who choose where they want to spend their twilight years without illogical statutes and regulations limiting their choices. That concludes my statement, and I would be pleased to answer any questions that you or the members of the subcommittee may have.
Mr. Retzner, you're now recognized. Thank you. Mr. Retzner, you're now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, thank you for inviting DAV to testify at today's legislative hearing. DAV is pleased to support the following bills. The SPORT Act seeks to include adaptive prosthesis, terminal devices for sports and other recreational activities in the medical services provided to eligible veterans of the VA. DAV has long recognized and continues to support the importance of adaptive sports through our involvement with the National Disabled Veterans Winter Sports and Golf Clinics, which helps veterans improve their physical and mental health by overcoming limitations and challenge their perceived disabilities. The Saving Our Veterans Lives Act aims to tackle the devastating issue of veteran suicide by providing secure firearm storage. Firearms are involved in nearly 72% of veteran suicides, and offering lockboxes creates time and space, reducing access to lethal means during moments of crisis, allowing veterans to reconsider their actions and seek help. The Marriage and Family Therapist Qualification and Veterans Health Administration Act aims to ensure that veterans receive care for high-qualified marriage and family therapists through effective supervision and improved therapeutic practices. Incorporating family and relationships into mental health treatment can result in more effective outcomes, reinforcing coping strategies, and provide a sense of belonging and stability. The Protecting Veterans Access to Telemedicine Service Act would ensure veterans can access controlled medications and consultations remotely, enabling convenient scheduling and thus improving treatment adherence and health outcomes. It breaks down barriers such as distance, mobility challenges, and transportation limitations, particularly for those in underserved areas. The Women Veterans Cancer Care Coordination Act aims to ensure that women veterans diagnosed with breast and gynecological cancers receive seamless and tailored support through regional care coordinators. This would ensure veterans receive timely and appropriate care. The START Act aims to streamline the referral process for veterans receiving community care, ensuring smoother transitions and reducing administrative barriers. By establishing a clear referral period, it would ensure better care coordination. The Providing Veterans Essential Medication Act aims to address the financial burdens faced by state veterans' homes, ensuring veterans have access to high-cost medications without added strain to the facilities. The bill guarantees continued high-quality care for veterans in long-term care, reflecting our commitment to their well-being. The Copay Fairness for Veterans Act aims to eliminate the co-payments for medications and preventive health services provided by the VA. Removing financial barriers will encourage routine checkups and screenings, leading to better overall health management and fewer emergency medical situations. We commend the thoughtful intent behind the next two bills and encourage incorporating our recommendations to enhance their effectiveness. The No Wrong Door for Veterans Act, reauthorizing and extending the Staff Sergeant Gordon Fox Grant Program, providing ongoing support for community-based mental health services. To enhance its impact, DAV recommends reiterating the importance of the original requirements of baseline mental health screening using validating tools and measuring the effectiveness of suicide prevention services with pre- and post-evaluations. Furthermore, funding criteria should focus on improvements in veterans' well-being rather than the number of participants served. And payment structure should be clearly defined to avoid overcompensation for minimal services. An annual renewal process is recommended until comprehensive data confirms the program's efficacy and identifies the most effective services in reducing suicide risk among veterans. The Veterans National Traumatic Brain Injury Treatment Act aims to establish a pilot program to provide hyperbaric oxygen therapy for veterans whose PTSD and TBI symptoms have not responded to traditional therapies. While initial research shows promise, researchers suggest further rigorous studies are necessary to validate its efficacy and safety. DV recommends amending the bill to prioritize research along treatment access to ensure veterans receive care that is both effective and evidence-based. In conclusion, these legislative bills represent a comprehensive approach to addressing the urgent needs of our veterans to receive the services and health care that they have earned. This concludes my testimony on behalf of DAV, and I'm pleased to answer questions you or the subcommittee may have.
Thank you very much. Ranking Member Brownlee, you're now recognized for 5 minutes.
Thank you, Madam Chair. Mr. Redser, thank you for your testimony, and I certainly appreciate DAV's support of the VA Marriage and Family Therapists Equity Act, as well as your support for the Women Veterans Cancer Care Coordination Act, which I'm co-leading with Representative Garcia. On the Cancer Care Coordination Bill, can you sort of elaborate a little bit more? I know you did somewhat in your testimony, but can you elaborate a little bit more on why this legislation would be beneficial, especially in the light of previously enacted legislation like the MAMO Act, which expanded veterans' access to high-quality breast imaging services, and the Service Act and the PACT Act, which expanded access to screening and made breast cancer a presumptive condition for veterans who were exposed to toxins during their military service.
This bill is very important to us on a couple of different facets. As in our written testimony, we outline the importance for our women veterans to get specialized care. That coordination care is so important in the challenge that VA has with addressing women veterans' special needs, especially when we look at, for example, breast cancer prevention. We need to ensure that VA, being that their infrastructure is not built to sustain all women veterans care at every VA facility, we rely on partnerships and affiliates to be able to supply the technical and lab work requirements, plus the clinical specialists that are out there to provide that care. Another thing that we saw that was really meaningful in this bill with regards to the care coordinators is the impact it has with honoring our PACT Act. Now that we have found that male veterans who have been exposed to toxic exposures can also be, unfortunately, suffering from the same illness of breast cancer, we feel that this piece of legislation will open up the door to developing good care coordination, not only for our women veterans who suffer with breast cancer, but also for our male veterans who have exposed to toxic exposures. So we feel it's very important with these research and the clinical findings that they work with.
Thank you for that. And speaking of the PACT Act, I mean, I have to ask you, with 83,000 folks being laid off or fired in the VA, and significant cuts to the PACT Act, what impacts, I think it's $23 billion cuts to the PACT Act, what are the implications of that?
Well, we are hoping for that the administration and VA and Congress itself work together in a bipartisan manner to ensure that these bills, and they're very thoughtful bills, continue to strengthen the VA system and that's the infrastructure, staffing, and technology needs.
Thank you. Dr. Kozmensky, in your testimony, you briefly discussed the importance of sufficient training and strict safety standards and the potential risks faced by patients who are seeking hyperbaric oxygen treatment for off-label indications like TBI and PTSD at health spas.
Yeah.
You also mentioned the recent tragic explosion of hyperbaric chamber at a facility in Michigan, which killed a 5-year-old child. Dr. Murphy's legislation, H.R. 1336, does not seem to include any limitations or guardrails on which types of providers veterans with TBI or PTSD could receive treatment from under this proposed pilot program. Do you think we should consider amending it to include safeguards, such as ensuring that veterans would go to institutions that have been accredited by the Undersea and Hyperbaric Medical Society or another body? And would you recommend other safeguards? The bill literally is like 2 pages, maybe 2.5 pages, and it's just about funding and having the program and starting the program, but no safeguards whatsoever.
Frankly, I mean, I do agree that it would be best to make sure that whatever treatment they receive, what our veterans receive, is done at an accredited facility. So amending the bill for that would be probably best for patient safety.
That's it?
Yeah.
Thank you. I'll yield back.
Thank you very much. The chair now recognizes Representative King-Hines for 5 minutes.
So more along the lines of this traumatic brain injury treatment option, and I guess this is a question for Dr. Retzer because it's a policy conversation, right? What additional research or oversight do you suggest or recommend is needed, basically, that we could actually explore this type of treatment, right, that a lot of folks support, and how do we ensure balancing the safety of our veterans?
I think as we see all the research that we've seen with what VA is doing and what NIH is doing, and also the Journal of Medicine, we're seeing all these factors that have progressed throughout the years, showing from a point of where there was an imbalance, where it was not positive that HBOT was producing the outcomes for traumatic brain injury and PTSD. But as we started to move through the years, we started to see some progress. And that's the promise that we're hearing, that we're wanting to see that more research. So as a resolution-based organization, we support research, strongly support continuation of VA's research, and also the research partners and their affiliates out there, to ensure that they are looking at safe clinical practices, evidence-based methods, to ensuring that we are providing alternative options of care for our veterans.
Okay, thank you for that. And this question is also for you. So given the importance of telemedicine in providing timely care to veterans, especially those who live in remote and underserved communities like mine, the CNMI, what specific safeguards are being considered to ensure that prescriptions for controlled substances via telehealth are both safe and effective?
Thank you for that question. And with pharmaceutical care and trying to address the issues of mental health and suicide prevention along with substance use abuse, there is a responsibility on VA to ensure when they are providing patient care in direct environment or in the community care that there are direct communication, clear communications on the treatment processes and what medications are given, so that the veterans themselves understand, being informed, what those interactions are and what the risk factors are, and at the same time that VA and community are speaking directly with themselves. For example, my time when I was stationed up in Alaska, very remote area, it is very difficult to find clinicians in every parts of it. So when you're dealing with VA and community care, and you look at their infrastructure up there, it is not built to communicate very directly or well. So we hope that as we continue with the modernization of the electronic health record modernization, that is something that will be worked very robustly into the system of the pharmaceutical safety measures, and making sure that patient safety is paramount throughout the whole development.
All right, thank you. I yield my time.
Thank you. The chair now recognizes Dr. Morrison for 5 minutes.
Thank you, Madam Chair. It's been my distinct privilege to join in the work that this committee leads, ensuring that VA is meeting veterans' diverse and evolving needs. As a physician myself, I've been part of teams that work together to help patients receive the highest quality of care and have witnessed firsthand the positive impact of building comprehensive care coordination that enables effective communication and supports patients through their care. With the number of women veterans expected to continue growing, obviously we should be proactive in our efforts to coordinate care for one of the most pressing health issues women veterans face. Mr. Retzner, you answered Ranking Member Brownlee's question. I'm going to direct it to you now, Mr. Dempsey, if I may, and thank you for being here today. We've highlighted that breast cancer is the most diagnosed cancer for women within VA, and that we'll likely see a rise in the volume of cancer care that veterans need. Can you expand a little bit on the importance of care coordination for improving health outcomes and women veterans' overall VA experience?
Of course, and thank you for the question. And thank you additionally for pointing out that breast cancer ranks as the second most common cancer among women in the U.S., and within VA, it's the most diagnosed cancer. I think for any veteran coming through the VA health system, but in this case, with the increased volume of female patients that VA sees, it's important that patients feel supported. With cancer care in particular, where a lot of that care is received in the community, it's critically important to make sure that there's good coordination between the VA direct care system and those community providers, so that there's no gap in service, whether it be transfer of records back and forth, communications between the providers to make sure that there's no gaps in care. And I think overall, just creating a culture where veteran patients feel supported by their care providers.
Thank you. I appreciate that answer. I'd also like to highlight another health issue that we've discussed that affects veterans at a 1.5 times greater than non-veterans. Suicide rates among service members have risen gradually over the decade, with veterans experiencing an alarmingly disproportionate rate of suicide by firearm. As the wife of a veteran, I find this absolutely heartbreaking. While we understand that mental health issues facing our veterans don't stem from a single cause, of course, it's important that we take any and every path to prevent these tragedies and empower veterans to address their mental health conditions. Safe firearm storage, education, and resources are integral to addressing the elevated risk veterans face for firearm suicide. With firearms reported to be involved in up to 72% of veteran suicides, as you noted, Mr. Retzer, the evidence for continued support of intervention programs that promote potentially life-saving time delays is clear. Mr. Retzer, in your testimony, you do discuss time and space as critical components in preventing suicides. Why is approaching suicide prevention through safe firearm storage particularly impactful for veterans and their families?
I can speak as a veteran who owns firearms and who suffers with mental health. And it's very meaningful to have this conversation because it is a responsibility not just of the veterans, but the clinicians and the families to be integrated to understand how to save their veteran and themselves. So in our testimony, we wrote about the community being safe. And that's the end goal, is to make that community safe, but where it starts is that veteran is safe. I have gone through the VA process of the clinical side, and I wish I was offered a lockbox. I was not. I met all the criteria that were actually testified, and I was not given an option for the lockbox. But the good thing is that VA throughout the process has been doing and taking steps to ensuring that they offer these security measures for our veterans.
Thank you. The Saving Our Veterans Lives Act considered by the committee today includes an education element. How do you anticipate the educational component of the initiative will work with the resource component of the bill?
That's a great question, and education is always very important, and that's something we, the veterans, have to also own for ourselves, for our responsibility. It's something that we come from. We come from an environment of being educated on how to handle firearms in the military, and hopefully that VA will build upon that knowledge that we have and the way that we were taught those, so that it relates to us in a manner that's meaningful, and it also highlights the importance. Education, I think, is going to be very important because it's going to open up the dialogue for us to talk about something that's not always easy to talk about.
Thank you, Mr. Retzer. You know, the legislative efforts considered in today's hearing demonstrate critical steps toward delivering the quality care that VHA should continuously pursue. I sincerely believe that finding common ground on ways to improve VA is a goal that's shared by all of my colleagues that sit on this committee. In recent weeks, there's been a lot of conversation about ramping up efficiency in our government. Every single one of the bills we've discussed today would require implementation actions that are the responsibility of VA employees. We cannot hope to continue to deliver care to our veterans if we throw the folks responsible for its delivery into instability and uncertainty. We can't wish for improved access to care if we allow the disruption of essential functions in our VA hospitals and facilities. We cannot tell our service members we value their well-being if we permit critical contracts and research initiatives to be slashed. I urge my colleagues, particularly those that have presented their bills before the committee today, to recognize
Your
the
time has
importance
expired. I'm sorry, we have votes that are coming up,
of
so please
supporting the
respect the
workforce.
time.
Thank you,
The chair
Madam
now
Chair. I
recognizes
yield
Dr.
back.
Dexter for 5 minutes.
Thank you, Madam Chair. And again, thank you to our panelists for being here and for the work that you do with our veterans. As I alluded to earlier, I spent my career in a comprehensive coordinated care system, very similar to the VA, and so I appreciate the ability to really embrace our veterans within the system and deliver care. I know that these systems work for patients as you've spoken to, and we have clear data that we'll submit for the record showing that care outcomes and satisfaction for care received inside of the VA is superior to outside. I also want to make clear that our veterans have access to care and mitigate the need for our veterans to be able to access care and have that intervention at the moment of impulsivity and despair for our veterans at high risk for suicide is critical. So thank you for your support for the lockbox policy. I think that is proven very high yield and critical. It also is critical that our veterans have time to talk with a provider, be able to reach out when they're feeling most impulsive and desperate. So I believe that that's the intention with the No Wrong Door Act, is to be able to help people at that moment. However, I'm concerned about our requirement for in-person care delivery for mental health care, and the fact that we are not going to allow telemedicine mental health any longer, that everyone's going to have to be in person because an established care provider is trusted and certainly preferable, having worked in an emergency room, to walking into an emergency room and expecting high quality personalized care. So despite the good intentions of the Wrong Door Act, it seems to run counter to the principles of a capitated, inclusive body. So I also have concerns about the reauthorization of a program for which we've collected good outcome data for only 4% of the participants. So I wonder, Mr. Retzer, if you would be willing to share your thoughts on when VA-led interventions are looking to be most impactful for our high-risk suicide patients. Do you feel like we have sufficient data to be confident that the No Wrong Door Act is actually saving lives more than further investing in VA comprehensive care and even mental health care?
Thank you for that question, and that is such an important issue that we have. A No Wrong Door Act really addresses alternative options where VA can't do it by themselves. That is something that we're very realistic to. And with having over 9 million veterans enrolled in the VA healthcare system, and you have 2.7 million in the rural, we have to be able to provide that type of resource. And when the Compact Act came out, and that was a great win for Congress and for American veterans to be able to get health care when they were in acute crisis, that is another tool. So the No Wrong Door has the potential to do what we need to do to provide alternative resources and clinical support out in the community where veterans may not be enrolled in the healthcare system. So I think that's the most important thing, is that we don't shut the door on this. We continue to see what we can do with this, and that's why we recommended our recommendations and testimony to be fiscally responsible, to make sure that it's not participants that are being engaged and we're not a production of veterans going through the shop. We want quality care, the same kind of care that we get within the VA system, and the wraparound services that were actually noted in the bill with regards to ensuring that they are going back to VA and being informed about how to utilize VA. So we see promise in there, but we're waiting for the report, and we hope to see the final report and become public for us to be able to make a determination.
And I absolutely share the intentions and the suppositions of the bill. I just am concerned about only 4% of output being really looked at for the outcomes. And it's not a question, it's just, I think that compelling data before we invest when we have so modest resources available to us is important. What do you think Congress can be doing better to bolster interventions to help prevent suicide, which is at a critical crisis point for our veterans right now?
Thank you for that question. I think, like I said earlier, it's multifaceted. We have to look at every avenue directly within the VA healthcare system, making sure we have proper staffing. We have clinical psychologists, psychiatrist shortages in staffing, but also to support them, we have to ensure that the VA staffing itself in general is up par. So, for example, if we go to the phone call for the crisis line, someone has to be manning that line. If we go to the phone to call the public contact office, someone has to be there. If we go into a VA medical center, the facility has to be cleaned where we have our people who are custodians that they're working. So all the employees that support the VA, it's very important that we look at it. The other thing is we need more peer-to-peer. Our veterans who work within the VA system, they themselves know what the life is like, and they have the experience to become peer-to-peer counselors or peer-to-peer to be able to mentor through us.
And I recognize that I'm over time, so thank you for your tolerance, Madam Chair, and I thank you for your testimony.
Thank you. The gentlewoman yields. The chair now recognizes herself. I was going to recognize Dr. Conaway, but he slipped out. Thank you very much. Ms. Morris, were there difficulties executing the construction of the VA clinic in Omaha, Nebraska in coordination with the VA? And if you could improve the chip-in authorities, what would you suggest if there in fact were difficulties?
We really did not experience a lot of difficulties in construction. If you remember, probably the biggest challenge was the last 4 months. COVID hit March of 2020, and we needed to finish up the project by the end of July in order to do the transfer in August. And our construction team and our design team worked diligently to be able to get that done on time, which was really kind of amazing that that was able to happen at that period.
Were there certain waivers or exemptions that you sought from the VA in order to get construction done under budget and under time?
Well, certainly I would reference the construction manuals and the security manuals. Those were critical. We actually spent a 2-day time period in Omaha, Nebraska, where about 15, 20 VA employees came out. We went through those manuals with great precision, and at that point in time, we were able to have value engineering of about $23 million.
Thank you. Dr. Kuzminski, many aging veterans and those suffering from diabetes-related complications, sadly, receive amputations due to chronic limb ischemia. Could HBOT therapies be potential preventive treatment for our veterans suffering from those conditions?
Just to clarify, so preventative in the sense of preventing those infections or preventing
amputations?
Yes. I do think that hyperbaric oxygen therapy has been a fairly well proven implementation for salvage therapy in those cases, for sure. Yeah.
Thank you so much for coming, and go Hawks. Mr. Harries, I understand the difficulties your members are experiencing as a result of the VA's inability to reimburse for high-cost medications that the patient may have been on prior to coming to a facility. VA testified the status quo is okay. Do you agree?
No, we do not. The increase or the costs of these drugs that are coming in are climbing rapidly. The other thing that is happening with the exposures to chemicals that our veterans are having, we're having more and more cancer diagnoses. Some of these high-cost drugs, or a good portion of them, are related to chemotherapy.
And they, in fact, cover these drugs if the patient was at a different facility or at their home.
Correct. And looking at it from a cost perspective, from the state veterans home, the average institutional per diem is $262 in cost for a state veterans home, whereas with the community homes, the private contractors, is $424. So if you looked at balancing that out, it may be a net neutral event.
Thank you. Mr. Dempsey, how could the SPORT Act assist post-9/11 veterans?
Thank you for the question. The SPORT Act would, I think, do a tremendous job of reforming the way that amputee veterans engage with the VA prosthetic department. Currently, with the limitation that adaptive and sport-related prosthetics only be provided as part of a clinical program. Expediting that process and getting these into a veteran's life is a great way to re-engage in the community, whether it just be participating in athletics, whether it be get involved in community outings, golf, running, any number of activities that I think a lot of people take for granted, but which can be greatly enhanced by better access to these prosthetics.
Does it seem to you that the VA's current status and parameters are geared towards elderly veterans who perhaps have amputations from medical conditions, such as diabetes, rather than to our younger, much more active post 9/11 veterans?
Well, thank you for the question. To be honest, I don't know that I could speak to that. I'd say that most of the voices that come to our post 9/11 serving generation are those who are injured in the early 2000s, for whom getting adaptive prosthetics became part of their post-injury life very early, and so they've become familiar with how to use them, how they want them, and so ensuring that the process works a bit more smoothly for them is the priority here.
Thank you. I yield my time. Thank you to all of you. Thank you to our witnesses and for all your thoughtful input. Ranking Member Brownlee, I'm going to ask if you have any closing remarks.
Thank you, Madam Chair. I just wanted to associate myself with Representative Dexter and Morrison and their comments that they have made today. And I will just repeat what I said in my opening remarks, and that I find it a bit crazy that we're having a legislative hearing today rather than an oversight hearing, while the Trump administration's careless executive orders, mass firings of VA employees, and reckless contract terminations are causing significant upheaval within the Veterans Health Administration. And as I said earlier, none of these bills we are considering today will address the very real threat to VA health care, to VA access to health care, quality, and safety that our nation's veterans are facing today. Veterans do not support these proposed cuts, nor do they support cutting 83,000 employees within the VA. If we continue to see efforts to dismantle the VA by firing hardworking employees, canceling vital research, terminating healthcare contracts, and eroding veterans' trust in VA, it won't matter what excellent legislation we put forth. There won't be employees or even an infrastructure left at VA to implement these bills, and veterans' care will suffer because of it. We can do better than that, and I yield back.
Well, thank you very much. And perhaps it's because I'm a physician and a 24-year military veteran married to a 30-year military veteran that I find it completely plausible that we as members of Congress can actually make legislation, go through legislation, in addition to respond to things that are happening through other parts of the federal government as well. Let me also say that I just need to address some misinformation I've heard here today, whether it's intentional or unintentional. There is a $6 billion increase to the Toxic Exposure Fund, not a decrease. Let me repeat that. The Toxic Exposure Fund in the continuing resolution that we may be voting on has a $6 billion increase. Let me also say that over the past 4 years, the VA's budget has increased $240 billion has increased from $243 billion to $369 billion, an over $126 billion increase, while nationally the level of veterans seeking care is level. And of that, in the past 4 years, an increase of 60,000 full-time employees and 23,000 part-time employees. So given my time in the military, I remember as an OR nurse, I won't say what facility I was in, it was 1:30 in the afternoon, all of the staff, with the exception of 3 of us, and I can see Dr. Kaminsky smiling because he knows what I'm gonna say, 3 of us were back putting together the instruments and putting up our instrument sets. Everybody else was in the break room. So I would say to look at how we spend money in the federal government, so precisely what Ranking Member Brownlee has said, so that we can continue to have the funds to deliver high-quality care to our veterans in a timely fashion, be it at the VA or in community care is a priority for all of us, and none of this dismantles or guts or defunds the VA or the Toxic Exposure Fund. I want to thank our witnesses who have been here today. I appreciate your coming and testifying. I want to thank our veterans, most importantly, who give us the opportunity to be here and to vote this afternoon. And on behalf of the subcommittee, I want to thank you all again, the witnesses, members who are here today, and I'm looking forward to working with you to address the issues facing our veterans. The complete written statement of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. This hearing is now adjourned.